how some of these newer vaccines work. The Oxford one is something called a virus vector, a harmless virus that the spike protein is inserted into. And so at the end of the day, you're getting immunity without doing your battle with SARS-CoV-2. And that's a good thing. So you're getting antibodies without having a risk of getting natural infection. And so fundamentally, that's essentially how most vaccines work.
Okay, thank you. I saw Dr. Van Turen was waiting to ask a question, but I see his hand is now lowered. Dr. Van Turen, you can raise your hand when you join the meeting again. Okay, I see he's back. Dr. Van Turen, you can unmute your microphone and ask your question. Dr. Van Turen, you just have to click unmute microphone and you can go ahead and ask your question.
Oh, unmute, sorry. I'm not like you young guys who are used to all this sort of Zooming. Anyway, first of all, the transverse myelitis that happened was with the AstraZeneca, I think, Oxford one. And I think the Oxford guys are now going to use trials before you can get the vaccine on ivermectin, but that's another problem. Our forefather of vaccine, where somebody else mentioned the vaccina from cowpox, was Edward Jenner. If I think Edward Jenner was practicing now, he'll be struck off anyway, because he didn't have phase 1, phase 2, phase 3. He just gave a kid 9 years old a little cowpox vaccina, which you scratch on the arm. So therefore, that you don't have to have all this phase 1, phase 2, phase 3, which we do have now. My feeling is that there are all this RNA vaccine coming out, plus Johnson & Johnson, plus Novavax. I've heard some people prefer the Novavax vaccine. Can Dr. Forbes tell us something about Novavax vaccine?
Dr. Forbes, did you hear the question from Dr. Van Turen? Sorry, Dr. Forbes, your microphone is muted. That may have been done by error. You can unmute your microphone.
Sorry about that, my mic muted. So absolutely, yes, it was the AstraZeneca vaccine that had the 2 neurological side effects that were mentioned. And I agree, we've come a long way from since we've been scratching cowpox and other ways of inducing immunity. But in that case too, it was also attenuated, so it didn't really cause disease. So the thing is, there are a lot of these vaccines that are currently in the pipeline.
I have now got, you know, those blue disposable boxes.
My apologies. You can resume, Dr. Forbes.
Not at all. So the thing about it is, there's actually about 200 vaccines that are in the pipeline against COVID-19. I think you were in the presentation last week, Dr. Van Turen, and not all of these are going to rely on the same technology as the ones that are receiving emergency use authorization at this time. So mRNA vaccines are for example, the Pfizer vaccine and also the Moderna vaccine. But we're seeing that the Oxford vaccine too is going to be a viral vector vaccine. But the Novavax is a National Institute of Immunology vaccine, and it's still in phase 3 trials. So we'll have to wait and see what that shows and how successful they will or won't be. So we'll see what happens. So some other vaccine houses, some have folded their cards and said that it doesn't induce immunity. And so we'll see. But certainly I think the landscape going forward will show different vaccines using different technologies.
Okay, thank you, Dr. Forbes, and thank you, Dr. Van Turen, for the question. We're going to go to the chat group because the questions are starting to pile up there. We have Dr. Shamanique Bodhi, who wants to know, do we plan to implement a vaccine program, and how do we plan to fund the vaccine?
So Dr. Bodhi's correct. So having vaccines is one thing, but it doesn't necessarily translate to vaccinations. And there are some fine nuances as it relates to having a successful vaccination program. So there's vaccine hesitancy that varies from country to country. In some places, for example, in China, almost 80% of people said that they would take the COVID vaccine when it's available. But in other places, that number declined 100%. And in some studies of Caribbean countries, the vaccine hesitancy was also very, very high. For example, I think Jamaica, their willingness to do this was about 30%. And there's often mistrust, especially in some communities, and our experience for groups that are at risk based upon previous bad experiences with vaccines, for example, the Tuskegee experiment. So all in all, we have to look at things seriously, and there does need to be a vaccination program. It has to involve education. You have to look at accessibility. You have to look at vaccine sites. Who's going to give the vaccines? What about storage? You know, one of the difficult things about these vaccines, some of them have to be kept at a very cold temperature, minus 70 degrees. And do you have the freezers for that? That's not something that usually a commercial freezer can do, or it can't go down to that super cold temperature. And so you've got to have storage facilities. We have to think about the specifications of our country. It's an archipelago. So how would you distribute these vaccines, especially if they have to be kept at cold chains? And all of this has to be looked at very, very clearly, because it has to end up in the arms of people. And you can see, before I go on and say that, in the vaccine vial, there's about 5, maybe 6 doses. Once it's out of storage and it's opened, it has to all be given. And so it won't do to only give 1 or 2 and then the rest waste. So all of that has to be well organized. That should be why there's a COVAX platform or a vaccination platform. And we're hearing there are various persons sitting on the committee to ensure that there can be successful rollout. If this is not done well, then there will be wastage of vaccines and suboptimal uptake of vaccines. And you will be in situations where you've distributed 30 million doses of vaccine and you have far less people taking it. So that does need to be looked at. I don't have the details for that. Dr. Dalregis is the chair of COVAX, but that should be some of the things that are being planned for.
Okay, thank you. Dr. Varunda asks a follow-up question or similar question to Dr. Bodhi, and it states, it can be noted that the cost of these vaccines vary considerably. Why shouldn't a small economy like the Bahamas choose a more cost-effective option? We can get more doses with the same amount of monies already paid.
I'm not too sure. I'm not following. Can I hear that again?
Well, I think it was more of a statement, but it basically states, it can be noted that the cost of these vaccines vary considerably. Why shouldn't a small economy like the Bahamas choose a more cost-effective option? We can get more doses in the same amount of monies that have already been paid.
Oh, yes, I agree. But remember, the vaccines for developing countries, they're going to come through the WHO platform called COVAX. And I don't sit on the WHO, but I've had to work with them in other ways. And so I've had view of some of their modalities and costing. And that is something that is taken into consideration, including not compromising things like quality and efficacy. And so I'm sure that will be looked at. That's very important. And when you think about having to deliver that task of having to deliver vaccines to the developing world, knowing that there's 200 billion doses of COVAX going to be made available in the first extrapolation and how many would be secured for developing countries, all of that has to be considered. It would definitely have to be cost effective. So I agree, cost is very important. However, these vaccines under COVAX, I don't think that they're going to come at a cost to the consumer.
Okay, thank you. Anyone that has additional questions, please remember to use the reactions tab at the bottom of the Zoom screen, and you can raise your hand and just be patient and we will get to your question as soon as we can. Just continuing in the chat as well, you can put your questions in the chat and we will ask Dr. Forbes. The next question is by Dr. Catherine Francisco Woodside, I believe. Can we propose a national registry for persons who have received the vaccine once it arrives? And that way, as physicians, we can tell if a patient has received it or refused it.
Yes, that's going to happen. And I think patients are going to be given a card too, but it's going to be monitored and evaluated.
Okay, great, thank you. Moving on to Dr. Sorry, my chat is a little slow. Moving on to Dr. Bassett. Good night, everyone. Given the multiple mutations that are arising, the possibility that this vaccine may not be effective against them exists. What will be our next step if this occurs? And will a booster offer protection?
Yes, good question. So scientists are looking at that. So let's start with the UK strain. It looks like the vaccination will cover that. There's a concern, maybe the South Africa strain, we're not too sure then. There are other strains. There's one that emerged in Brazil and several in the United States. And scientists are looking at that. And yeah, so if that happens, the vaccine will have to be tweaked a little bit so that it can cover those newer strains. We might see that happen. That could be a reality as mutant strains arise. And I think one of the renowned ID doctors said that the answer to that is to stop, to get on top of outbreaks so that less mutations are happening.
Okay, shifting gears to some of the questions that patients have asked physicians that they submitted to the group. Is it safe for persons with pressure and heart problems? And can persons with chronic infections such as sinusitis, lung disease, take the vaccine?
Yes.
How will I know if I'm allergic to the vaccine?
You won't know, but most of the studies, those persons who did develop an allergic reaction, they had a history of allergies. Almost all of them had a history of serious, severe allergies, either anaphylaxis or hives or swelling of the lips and tongue with foods or medicines. And so there, like I said, there's a CDC recommendation that in that case, one should use caution and consider not taking the vaccine. Oh, and by the way, at vaccine sites, persons are going to be asked to wait for 30 minutes to observe for signs of allergy. And there's going to be support like a crash cart and other medicines there in case an allergy is developed, but it does not happen very often. It's uncommon.
Okay, thank you. Moving on to Dr. Christine Chin. Good evening. If some doctors and nurses are hesitant to take the vaccine themselves, how are they going to be advocates for vaccinating the?
Yeah, that's a good question. I don't know if I'm the best person to answer that. Maybe we need a psychologist or a psychiatrist or some behavioral person to answer that. But I hope that all of us here, that we're able to separate our personal thoughts and feelings from medicine. And I think that there could be other things that we don't necessarily agree with personally, but we offer good medical care and standard of care. And these vaccines are standard of care. It's a good question though, because just last week in the news, in the United States, there was a site where 3 of the nurses said that they did not feel comfortable administering the vaccines, and so they were then replaced with persons who were willing to do that. But I do think that this could be a good place to say that our what we say and our attitudes and how we advocate does make a big difference in terms of the public and their thoughts and perception.
Okay, great. Dr. Chin, says thank you for answering her question.
You're welcome.
If anyone else has any additional questions, please feel free to raise your hand, to click the reactions tab and click raise hand, and we will allow you to unmute your microphone and ask Dr. Forbes the question directly. Okay, moving on to Dr. Halkitis again. She asks, I'm sorry, just a little slow on my chat. She says that it is concerning that there is only one physician on our vaccination committee, and that is Dr. Dal Regis. We will likely require, oh, this is a separate question, so I guess we can mention that. I guess that's just a comment. Other than that, she says, we will likely require a vaccination card to travel in the future, and we talked about that. And let's move on to Dr. Marcus Bethel. Having access to vaccines is one element. The other is getting people vaccinated. Okay. And Dr. D. Farquharson, he has a question. And he says, experts are now discussing the Pfizer and Moderna vaccines as treatments not to be inoculated with these agents. Meets the
is what you do. Disease, go ahead and give vaccine around the same time you're giving prophylaxis. But we need more information on the field and things like that come on stream. But it will be interesting because, you know, there's these monoclonal antibodies and Regeneron and all those things, but we're still looking at COVID-19. But let's wait and see what the evidence is going to be on that.
Okay, and what you want to do, RNA needs to defend the spike protein produced by the mRNA.
So there are various modalities for in general about how you make a vaccine. You take a perfectly harmless virus and insert a part of the protein for the virus you're targeting. That is how a vaccine works. So there are going to be vaccines that without the mRNA to express the spike protein transiently. So yes, we're going to see other vaccines coming along.
Okay, I'm on your phone. You have to forward your question.
I'm not hearing Dr. Cooper.
Sorry, just go ahead and unmute your microphone one more time. Thank you.
Is that better?
Yes, I'm hearing you now. Hi, Dr. Cooper.
Hi, good night. How are you?
Hey, how are you?
Fantastic. Quick question. Do you have any information about how these vaccines work in people who have immune-based chronic illnesses? I've been doing some preliminary research on the two vaccines that are currently available. Mm-hmm. And one of the terms that kind of interested me during this research is the biodistribution of the vaccine. So we know that when the mRNA particle is given in the lipid nanoparticle or whatever, it's taken up primarily by immune cells like macrophages, but it's also distributed in other tissues. It's taken up by the lungs and the liver and in the nervous system in smaller amounts than it is in the immune cells, but it's still there. So I'm wondering if any of the vaccines have included any persons that are on immunosuppressants or that have these chronic immune-related diseases, to see how they would actually respond to it and what would be your recommendation for these people whether or not they should or should not take the vaccine?
That's a good question. I would have to go back to the clinical trial to read if those persons were included. However, that same question came up at IDSA vaccine panel that I went to about a week ago. And experts are recommending that people who are immunocompromised, including those that are on immunosuppressant therapy, do get the vaccine, because certainly know that they're at risk, right, for having a bad outcome or severe disease if they get COVID-19. So the thing is, though, I mean, at the basic core of how these vaccines work, like the mRNA vaccine, well, I know you already know, but I'll just reiterate it, which is that it's introduced in a lipid particle to protect it, right? And it doesn't enter the cell's DNA, like the helper T cell usually is the one that is going to be responsible. And so it's going to translate so that those cells transiently, very transiently, minutes to hours, express the spike protein so that an immune response could be mounted. And then they're disintegrated thereafter. But what you or the person would have gotten is an antibody response and a memory response. So based upon that based on that physiology or mechanism of action, there should be no reason that an immunocompromised person shouldn't get it.
So the other part I question is somebody who has an exaggerated immune response with this biodistribution that I'm talking about being taken up by other organs, other tissues that are not a part of the immune system, and the possibility of them developing an immune reaction at some point in time at a later date to these tissues, to these organs, sort of an autoimmune response to the mRNA that's taken up by these cells, by these tissues or organs.
Well, it hasn't been effectively demonstrated at this point, right? I think that it's unlikely because, like I said, it's very transient. So that whole mechanism of action is very short. It doesn't happen forever and ever.
Okay, I mean, I guess it's just something that that we'll have to watch for. We're gonna have to monitor these patients. It was one area of concern that I've read that some other people have had, this biodistribution thing, because not all of the mRNA is taken up by macrophages. Some of it gets into other tissues, and the possibility of having immune-related diseases or an immune response to these tissues that have taken up this mRNA is possible in the future. So, just something that remains to be seen, and we'll just have to watch and see what happens.
Thank you, Dr. Cooper. We appreciate the questions. Moving on to Ms. Bassett. She says, for those persons who have allergies, would it be best for them to wait for the more traditional attenuated vaccines, such as the Johnson & Johnson vaccine?
Quite possibly. If you have a severe allergy, so the whole thing about vaccines is risk versus benefit. So the label precaution is saying now that if you have a severe allergy to food or medication, hives, angioedema, or anaphylactic response, then there's a caution for the COVID vaccine. But I think if it's very mild, if it's not a severe allergy, it's not contraindicated.
Okay, thank you. Do we respond? Oh, sorry.
Dr. Franson here. Just to go to the last question before. That was answered that Dr. Cooper had raised and made some comments on. I think one factor that has to be remembered is that the mRNA is very, very unstable and therefore has to be kept at very, very cold temperatures, which does not speak well for it lasting long enough in the body to do any reverse transcriptase activity or anything like that, but it will degrade very rapidly. That is what the present thinking on that. So things like having long-term immune effects or autoimmune effects, etc. The probability seems to be very, very close to zero.
Okay, Dr. Forbes, do you have any comments on that?
Yes, I think I said that. That it is very transient, and it's not going to be around forever. So it's not very likely. But I agree. Thank you, Dr. Frankston.
Yes, thank you again, Dr. Frankston. I appreciate your comments. Dr. Marcia Bassett, do we have any preliminary results from the healthcare workers survey on interest in receiving the vaccine?
That is a good question, but it's not my platform. I don't have view of that survey or the preliminary results. I couldn't speak to that.
Okay, great. Just want to remind everyone we're approaching the 1 hour mark. We're trying to answer everyone's questions. Dr. Forbes has graciously offered to spend our evening with us. So any burning questions, please click the reactions tab and click raise hand, and we will be sure to get to you. Or you can type your question into the chat box and I will read the question to Dr. Forbes. Dr. Bassett, I don't think I read that one. Dr. Bassett, 1 second. Sorry, Dr. Forbes, just having some difficulty with my chat. Okay, so Dr. Bassett also asks, do we have, no, that's the same question. Is there a recommendation for long after infection should vaccination occur?
How long after infection should vaccination occur? Is that the question?
It seems that is there a recommendation for long after vaccination? I'm guessing that's what it is. Yeah, I think there's a little confusion with the question, but basically with the way you said it just now.
Yeah, that's a good question too.
I'm guessing that,
and it's being discussed by
right.
experts. So after natural COVID-19 or getting SARS-CoV-2, there will be some immunity. And how long does that last? It could be months for some, it could be years. It's not totally clear, but there will be some protection. And so what experts are saying is that you should get the vaccine still because of the risk of strains and other strains and the very uncommon at this time chance of getting reinfected. And so maybe as early as 3 months after the first infection, one could consider starting the vaccine series, but you have a little wiggle room because there is some immunity. You could push it to 6 months. But then what happens if you start by getting the vaccine series? You know, some of these, it's a series of 2, and there's anywhere between 2 weeks to 4 weeks before getting the next booster, the next series, let me say that. So people are saying that if you do get COVID-19 after the first vaccine, you've gotten better, you don't have fever and so on, contraindications on that day, you could still get the second vaccine on the day that it's scheduled, but you could also delay it up to 6 weeks. So yes, you can still get the vaccine on a case-by-case basis, of course, weeks after the infection, weeks to months.
Okay, Dr. Van Turen, we're going to get to you next. I just want to ask one more question from the chat group from Dr. Bodie. Is there any information on the efficacy of the vaccine in persons who have had COVID? How soon after infection would you vaccinate?
Yeah, so that's kind of a bit like the question before. So if you have had COVID, you do have some protection, but you know that it's possible you could get reinfected or infected with another strain. It's not too sure when, but how long the immunity would last. It could be anywhere. You could get the vaccine anywhere 3 months after, weeks after. Of course, the contraindications would be if someone is acutely ill with febrile viral illness, they wouldn't get the vaccine on that day. But yes, it's still an indication to get the COVID vaccine if one has natural infection.
Okay, thank you. We're going to go back to Dr. Van Turen. You can just click unmute your microphone and ask your question to Dr. Forbes.
Thank you, Dr. Forbes, for your answer. If we get the vaccine, the next problem is distributing them like they did in London, but they sorted out by getting ex-nurses and all that giving the vaccine. But once you give the vaccine, let's say 40 days later, do you do the antibody test to see whether they get a positive reaction, or do you wait till they get a second vaccine before and wait for 14 days before you do another antibody test? That's my first part of the question. Obviously, we never know how long, like you said before, how long the immunity will last. I personally did one on my patient that I did mention that he lasted 10 months. And I did him again last week and he was negative. So that goes boom, my expectation that it might last longer than a year even. But next question I want to ask is, we are very touristic minded on this island. There is another island that I've just heard in the Maldives, which is very touristic. They got nothing else except tourists. That India has given them the COVAX for all the workers on their island so that they will be so-called immunized, then they can attract the tourists back again. So there's two parts to my question, and I'd be grateful if you could answer them and see what your opinion is.
Okay, thank you, Dr. Van Turen. So at this time, it's not really recommended to do an antibody test to see if someone is eligible for the vaccine or to prove that they have mounted a sufficient immune response after getting the vaccines.
Good, thank you.
So you don't, not needed.
Okay.
Very interesting what your observation was in your patient. So there's just a lot we just really just don't know yet, right? I mean, for those, you know, immunity varies from person to person. Even with those other coronaviruses, some people had it for up to 2 years. Some people had it transiently, it was just a few months. Like I said, how do we, I mean, who knows why? Is it the exposure level? I don't know. Is it ongoing exposure? We could be talking about that all night. It's a very theoretical discussion, but you don't need to do an antibody test for determining if someone needs a vaccine or to prove that they have had immunity. And be cautious with using antibody tests, even for diagnosing acute infection. Is not indicated for that. There's a very narrow indication for that. And you can see that on the WHO site. It's something about negative PCR symptoms and so on. And maybe they have viral symptoms and did they have COVID? It's I don't know that it actually changes clinical practice. Let me just say it like that. Tourism and COVID, very interesting because it really has upended tourism globally. And as you can see, the cruise industry, it's not going to be resuming anytime soon. And many destinations that are dependent on tourism are having a very hard time, and places that are not fully dependent on tourism are also having decreases in their industries. To say broadly about COVID and tourism, it surely looks like we might see immunity cards or vaccine cards, or something like that, introduced or requested at the border. I'm sure that the most scientific agencies don't like that, but it is probably going to become a reality. And then when one considers who gets the COVID-19 vaccine, there was a slide I had in my presentation that looks at rollout and who do you give it to and first. And it has to be fair and equitable. You know, really, that's very important. And so it should be people who are most at risk of having a bad outcome if they get COVID-19. And then it should be people who their risk is much higher than others. It's far higher than others. For example, healthcare workers could be one example, or frontline workers. And then it should be persons who, if that group of persons is not able to function in society, there's huge fallout. For example, healthcare workers, if we're all exposed to COVID-19 and we're all at home on quarantine, who is going to do what we do? And there are other persons, like maybe police officers. I am just saying this hypothetically. I can't speak to that from an IED point of view, but one would have to look at that. And where does tourism and hospitality workers fit into that? And so in that country, in their context, they may have a very, very high risk because, you know, COVID, there is a risk associated with travel and people migrating for travel. And so that may be the reality of their context. And so that's all I really could say to that. But there are some very interesting points as it relates to COVID and tourism. And like I said, the accessibility and equitability of vaccine rollouts.
Yeah. No, I'm just saying that in India, they seem to have this COVAX thing that it can make it by the millions. And I've heard that they even gave Nepal about 1 million vaccine and about 10,000 to Maldives. So therefore Maldives can carry on with their tourism thing because that's all they have. Mm-hmm. But the COVAX vaccine, I gather, is, if I'm not wrong, correct me, is an inactivated virus, not RNA, not recombinant with, well, it may be recombinant, I'm not sure. But is it easier to make the COVAX type vaccine than the mRNA?
So I wonder if you're talking about the Serum Institute of India. Is that the platform you're talking about?
Yeah.
That's a viral vector vaccine. So it just uses a different technology. But we see that that's the same vaccine that the Oxford AstraZeneca is, and that had a similar timeline to the other mRNA vaccines. But I don't know, I'm not being a vaccinologist about how long it would take to do so, but it doesn't really take all that long to make a vaccine once the exploratory phase is there, and there are other platforms, and these are not new technologies by any way, shape, and form. So the last thing I would say on that is, because there is things like the Serum Institute of India, they probably would have more accessibility because they would have the ability to be able to manufacture vaccines for their population, and that would help.
Thank you, Dr. Van Turen, for your excellent questions. Dr. Forbes, we're wrapping up at the 1 hour mark. I just want to ask one last question from the chat group, and then we will call the meeting to a close. This one is from Dr. Philip Kurian. Do you think if the vaccine is going to be a part of the flu shot from next year, considering we don't know how long its effects last?
I suspect so.
Okay, great. Thank you. All right. I just want to thank everyone for attending the meeting. We approached about 200 persons at one point. So thank you guys for spending your evening with us to become more educated about this vaccine. And thank you again, Dr. Forbes, for spending the time. I just want Dr. Dorsett to have some closing remarks, and everyone have a good evening.
Good night again. Thank you so much, Dr. Forbes. You did an excellent job in answering the questions. Very quick, very confident. And, you know, it gives us a better feel and a better grasp on the vaccines themselves. In the upcoming days, there's going to be, everything seems to be moving so quickly. The thing with COVID, the whole coronavirus infection is, it's not giving us time. It's not giving us time to stop and think. We have to be, our feet have to be on the ground at all times, just moving in an effort to keep up with it, not even to get ahead of it, just simply trying to keep up. You know, I had an opportunity to speak with Dr. Dal Regis today about the vaccine, the planning committee, etc. For one of the doctors to gain access to that committee so that we can have a voice and that person can act as a liaison that brings us the information, that we have that discussion that's so readily, you know, so we really need to have that discussion among the doctors. And in the long run, we are going to be called upon to assist with the administration of the vaccine, like Dr. Nikkiah Forbes said, you know, we're going to have to be there in case there's an allergic reaction, etc. So because, you know, we are a major stakeholder in this. So, you know, again, we really need to have that voice at the table, which seems to be coming along. And also, we're going to be looking for volunteers to assist. We're going to have to be up on the information to be able to reassure the public, you know, even among the medical faculty, we are having questions, we're having concerns. We're trying to, you know, to get our own feelings on if we are going to be vaccinated. And again, in order for us to reassure our patients, we have to know where we stand. So in the near future, yes, we have a lot to think about. I encourage each and every one of us to try and work together. You know, at the end of the day, we need to get the information out to the physicians. We need to get the information out to the general public. And remember, this is our Bahamas. You know, this is our sisters, our brothers, our aunts, our parents. So we need to be up on the information and we need to be willing to go out there and assist. But we can only help others when we ourselves, you know, are we need to put ourselves in that position. But tonight I say thanks to all for coming in and participating in this discussion. And again, thank you, Dr. Forbes. You did an excellent job. Excellent. And thank you guys for being very attentive and asking the pertinent questions. You were on point because a lot of those were questions that we had ahead of time. Again, thank you all.
Thank you. Thank you for inviting me. Have a good night, everyone.
Good night.
Good night, everyone.